Good evening, and thank you for joining us tonight for the third webinar in our secondary progressive MS series, How to Maintain Your Physical Well-Being. This webinar is brought to you by Can Do Multiple Sclerosis in partnership with Novartis. My name is Laura Allen, Programs Manager for Can Do MS. I will be your moderator this evening. Can Do MS delivers health and wellness education programs to help families with MS thrive. Please visit the Can Do MS website, cando-ms.org, to learn more about Can Do MS's online and nationwide in-person programs. Our speakers this evening are Kathy Healy and Mandy Rohrig. Kathy Healy is a nurse practitioner with the University of Nebraska and an assistant professor in the Department of Neurological Sciences. She has been caring for people with MS for over 20 years. Mandy is a member of the American Physical Therapy Association and currently works in an outpatient physical therapy session where she specializes in the rehabilitation of individuals with neurological conditions, with a special emphasis in the treatment of individuals with MS as well as balance and vestibular disorders. And now, I would like to turn the meeting over to Mandy.
Welcome, everyone. We're glad to have you this evening. We're going to start with our learning objectives. First, learn strategies for managing complex or worsening physical symptoms related to secondary progressive MS. Become familiar with the concept of reserve and appreciate the role of wellness in optimizing this reserve. Learn how to prevent and manage secondary complications and comorbidities that can contribute to MS progression. Understand the critical role of exercise in overall wellness and how it can be adapted to different abilities and schedules. Become familiar with the types of adaptive equipment that facilitate safety, independence, and active participation. And lastly, but certainly not least, learn practical, energy-efficient, cost-effective strategies for healthy eating in the face of disease progression. So we have a lot to cover today, and we're going to start out with talking about secondary progressive MS and reserve.
So welcome, everyone. What is secondary progressive MS? So we know without treatment, these are natural history studies, about 50% of those living with multiple sclerosis, with relapsing remitting, they transition to a secondary progressive stage of MS within about 15 to 20 years. And again, that's without treatment. And approximately 90% of patients with disease duration over 26 years will have transitioned into more of a progressive course of MS, again, without treatment. This is a clinical diagnosis. There are no blood samples we can take to tell us that someone is in progressive MS, or really no specific indicators on MRI. We do know that disease modulators do alter the course of MS and likely will delay progressive MS. Many of, at least my patients, however, were diagnosed prior to 1993. And we know that our first agent came on the market in 1993, and there was somewhat of a limited selection of meds too. So progressive MS, during that time, patients generally will experience a gradual worsening of existing neurological signs. And usually it's past injury that has occurred during a relapse or new lesions on the brain or the spinal cord. And so what you may be feeling in a secondary phase of MS is progression of what you have already had to deal with. Maybe some additional problems with walking, balance, sensation, maybe pain, fatigue, maybe more cognitive dysfunction, possibly more bowel and bladder. Visual function also can be an issue. And even with stable MRI findings in this course of disease, there can be progression, and we're trying to figure that out and why that actually happens. Next slide. So a good model, I think, that at least clinically explains why there be more progression in this stage of disease is Dr. Stephen Kriegers topographical model of multiple sclerosis. And I don't know if everyone sees, this is what I call a fish tank. And so here you see this side of the tank is more shallow, and here is about a medium depth of water, and here's a deeper depth. But part of the concept here is that where lesions are located probably do matter. And lesions in the spinal cord, and that's what this end is about. This is spinal cord and optic tracts. Those are smaller structures. And so if you get a lesion in those areas, typically it's going to be clinically evident. So patients usually report relapses. So that's why there's less reserve, because these structures are smaller. And here is the brain stem and the cerebellum, and these are also smaller structures in the base of the brain and our balance center. So the water is a little bit deeper there, so there's a little bit more reserve because there's more volume of tissue. And then here, where the water is quite deep, this is the cerebral cortex, and those are called where subcortical lesions are. And those areas are very big within our brains, and there's a lot of redundancy. So you can have quite a few lesions there and really not feel it so much until, you know, possibly later. So what this is the water level, and that's what we're going to talk more about today, is what we call reserve. And this is kind of what this is all about. So what happens is that our central nervous systems, there's just so much tissue, and with multiple sclerosis, there is injury. So our reserve goes down. As we age, everything shrinks. So our brain shrinks, our spinal cord shrinks, our skin shrinks, everything shrinks. So this is why we think that after 10 to 15 years of disease onset, people start feeling these clinical symptoms which were not really apparent before. I mean, maybe with the relapse. But so it's all about this water level and keeping that up. So it's, you know, we can't delay aging, so we know that's going to happen, but other things can affect reserve, like just our general health. For instance, if you get an infection, that water level goes down, and you probably all have felt that too. When you get an infection, symptoms get worse, and in fact, many times they hallmark an infection when your symptoms are worse. And heat can bring that level down, lack of sleep, other medical conditions, or what we're going to talk about, comorbidities or other complications of MS, can bring that level down. So what can bring it up? Things like healthy eating, healthy diet, exercise, good sleep, avoiding any infections or other medical comorbidities. All those things keep our reserve up and optimize. And so what we think that, you know, that's going to help temper that slope, that progression, so much so that we see many people plateau when they are at optimal health, they're exercising, they're socially engaged. So the next slide, we'll go over this quick, but here's just the different stages of multiple sclerosis. Here's relapsing remitting, where here's a relapse and you actually feel that, but then it remits. And while the water level is high, then people generally don't have any issues until the water level gets lower as the reserve decline. And then those things start to become more apparent in everyday life. So I hope everybody understands that. It makes sense to most of us that do MS in clinics. But so the remaining part of the talk is going to be all about how to keep our tank full, basically.
So what does secondary progressive MS look like? Just like everything else in MS, there's no consistency. Some folks who have secondary progressive MS can be using a wheelchair. Some folks can be walking with an assistive device. Some people are using power mobility. So there's a significant amount of variability in what the presentation looks like physically. Next slide. So what does secondary progressive MS feel like? People often talk about how they feel like they're running out of water. They feel like their tank is empty. They feel hopeless. They feel like they should have done something differently. There's a lot of self-blame. There's a lot of uncertainty, unpredictability, kind of this confusion, this loss of purpose and identity. So it's really difficult when people kind of make this shift from relapsing to secondary progressive MS. So Kathy, I'm just curious, when you know that a patient is starting to make that shift to secondary progressive MS, how do you talk to them about that? How do you help them understand how that change is happening?
Yeah, it doesn't happen overnight. This is a course of disease, and there can still be active relapses and secondary progressive MS, but generally when symptoms start to worsen. But what I usually tell people, in this phase of disease, it tends to be later. So the good news about this phase of disease is that you're less likely to get a new event or less likely to get new lesions. Although not impossible, but less likely. But you're more likely to have to deal with the things that you've already have, and they may progress. But the really key of this all is, to prevent any new relapse, which can happen, but also to keep that tank full. So all of those like optimal health strategies are highly important in this phase of disease.
Great. Next slide, please. So in addition to what Kathy's describing, what she's already spoken of, is we also see this shift. So perhaps the healthcare team that you had with relapsing MS, maybe now that you've shifted into secondary progressive MS, there are more members of your healthcare team. There are more symptoms to manage, more issues to be addressed. So your healthcare team is broadening, and you may find yourself a bit overwhelmed at times with all the appointments and things that need to be managed. But just be confident that the healthcare team available to you is hopefully helping you address your needs. So Kathy, let's go ahead and move on to talking about some of the secondary complications related to MS and the comorbid health conditions that people can address.
So comorbid health conditions are other diseases that are more likely to occur with multiple sclerosis. And there's been a good amount of research done on this. And so those things we know that are more likely in MS are things like diabetes, peripheral vascular disease, high blood pressure, high cholesterol. We're going to talk a little bit more about depression and anxiety. Those are also comorbid health conditions that have a higher incidence in multiple sclerosis. And then common secondary complications. And secondary complications meaning that they are due to some of the symptoms of MS, for instance, immobility or gait dysfunction. So those secondary complications are infections. The most common infection is bladder infections or urinary tract infections, but we see respiratory infections. Falls are frequent in MS, as I'm sure that a lot of you have experienced. Falls with fractures can really lower that reserve. There's no question about it that after hospitalization, even with a fracture, you may not get even back up to the baseline. So we want to avoid those sorts of things. Skin ulcers, pressure sores, if you are using a wheelchair or immobile, are also a secondary complication of immobility. And there can be weight gain or weight loss. Sometimes it's difficult when you can't move around as much and there is weight gain. We do have some individuals who start to have some issues with swallow, and there can actually be weight loss. But all these conditions and complications can be managed, and that's the good news. It's hard work, but it's very much worth it. Next slide.
So I cannot control my bladder anymore. We're going to go through a series of vignettes. Let me back up. We're going to go through a series of 1 or 2 sentence vignettes that pull out some of these key issues that people with secondary progressive MS and their loved ones may be struggling with and trying to figure out how to manage optimally. So this first one is, I cannot control my bladder anymore. I don't want to go out because I'm afraid I will have an accident. Plus, I get a bladder infection every month. Unfortunately, quite common. So we're going to ask you all a polling question. Do you or your loved one with MS experience bladder challenges? Yes or no? And we'll give you all just a moment to answer. And overwhelmingly, the response is yes. So bladder issues go beyond just the bladder. There are a lot of social challenges that are associated with this. So let's talk about how to keep our tank full, how to optimize our reserve when it comes to infection management related to the bladder.
So especially when we have bladder infections, that can lower that tank, lower the reserve, and it can be associated with more, progression, especially at that time of infection. So what most of my patients tell me is that because of bladder frequency and frequent trips, they restrict fluids, but that in fact is probably the worst thing to do. Hydration is the #1 way to prevent urinary tract infections. And I know it's tough when there's frequency, but that is the #1 thing. So with frequency, and I think someone, Dr. Shapiro, is talking about more medical management, but with frequency, there can be some incontinence too. There is a multi-million-dollar expenditure on incontinence materials just because all of us baby boomers are aging and incontinence happens. And so it's not your mother's adult briefs, if you will, but these products are much more attractive, and they're better, they're more absorbent. So if that's what keeps people hydrated and keeps you from having to run to the bathroom and maybe risking a fall, I mean, it is certainly worth it. It's a different way to live, but it can be a new normal. So we tell our patients to try and hydrate, and it's tough to get that hydration in. We recommend 2,000 cc's or 8 cups of preferably water a day, and that's hard to do when you're taking little sips. But so what we usually do, I mean, is tell individuals to put these together with either their meds or a meal, and maybe have 2 or 3 cups of water prior to a meal, prior to meds. In addition to that, if you're dealing with weight issues, it can be helpful also because it kind of fills you up. But if you can, take those large quantities of fluids at one time. A lot of people would just do tap water because that's easier to get down faster. So many people will, when they brush their teeth or they take their morning meds, have 3 cups of water right out of the gate, and again around lunch, and then again before or mid-afternoon. We also recommend that people probably stop hydrating between 6 p.m. and 8 p.m. at night because you don't want to be up all night. Another kind of trick to this is if you are up at night, and there can be falls during that period also, as bedside commodes are useful, especially if you've got a ways to go to the bathroom. And if anything that can prevent a fall is a good thing. Also, males can use just urinals. Simply put that down on the floor next to the bed instead of, traveling to the bathroom back and forth at night. Condom catheters for males. This is a picture of one of those, and that slips right over the penis, and usually it has a tube that attaches to a leg bag. So many of our male patients, especially when they're going to all-day events, will use these. And those are available on the internet and through urology offices. Next slide. So in addition to adequate hydration, another way to prevent especially urinary tract infection is to always urinate, especially females, after they have sex. That's just a standard practice in preventing urinary tract infections. It's a little bit awkward, but you just get up and go to the bathroom. The other thing that you should all know is know your residual urine amount. So if you start to retain urine, which is possible, your risk for urinary tract infections are higher. So know your residual amounts. Generally, individuals should be checked for residual urines at least once a year and maybe twice a year. The normal is about 120 cc's. Anything above that increases the risk of urinary tract infection. So just know your residuals. No symptoms of urinary tract infections. Usually that's pain, burning on urination, but some people don't get that because they have numbness. Elevated temperature of anything over 100 usually is a symptom, blood in the urine, and you probably all know the significant worsening of a baseline symptom, especially spasticity. That can herald a urinary tract infection. The other kind of challenge in urinary tract infections is sometimes people are overtreated. So just because your urine is odorous or cloudy doesn't always mean you have a urinary tract infection. It certainly could, but other things can cause those sorts of things, like multivitamins can cause a strange smell in your urine. Different types of foods, dehydration can cause your urine to look dark and cloudy also. Keep track of urinary tract infections. If you have more than 2 in 6 months, that's kind of a red flag that things need to be checked into. Next slide. So if an individual has to go to a catheter, and we absolutely want to try to avoid those sorts of things, because when you do have catheters, it increases the risk of urinary tract infection. But there are some reasons that people do need catheters. The first one is urinary retention. So if you aren't able to fully empty your bladder and you get recurrent urinary tract infections. The second one is trying to get to the bathroom and falling. Just lots of falls when trying to get to the bathroom, and that can be a reason to put in a urinary catheter. And the third one is incontinence that is causing skin breakdown or ulcers on the skin. So those are some of the reasons. If you do have to use a catheter, it's not what your normal is, but it's certainly sometimes they are actually very helpful for patients, especially if they're running all the time to go to the bathroom. I've had people say, you know what, this is really nice. I can go to my kid's house and not have to worry about being able not to get in their bathroom. So catheters also have come a long way. This first one here is an intermittent catheter. So this one, males or females can do this. These are very small, and they're inserted into the urethra or the urethral meatus or the penis in a male. And so it's inserted, it's pre-lubricated, and it drains all the urine out, and then you dispose of it when you're done. Very tiny, it can fit in a purse or a pocket. That's an intermittent catheterization. You do have to have some fairly good visual acuity and dexterity to do those. And then the other types of catheters are indwelling catheters. There's 2 types. There's a urethral catheter and a suprapubic. Urethral catheters, the tubes go through the urethra in a female or through the penis in a male, and they just stay there. There's a balloon that keeps it into the bladder, and you can attach it to the leg, or there's a bag. The other, the important thing here is, again, hydration, because you are at more risk with these for infections. There's another type of catheter called a suprapubic catheter, and that actually goes right into the lower part of the stomach. It's done as an outpatient procedure, and here's a male, and here it is, and then here's a female. And the risk of infection may be a little bit lower with these types of catheters. The benefit is that, you can have sex really quite uninterrupted here, because the catheter is right here in the abdomen. Many people, when they do have sexual intercourse, will loop the catheter around their stomach and use a piece of tape. So it's kind of out of the way. So these can be helpful, especially under those conditions when people do need them. Next slide.
So in addition to all of the strategies Kathy has just outlined, there are some strategies and some ways that rehabilitation and a dietitian could potentially help you with infection management with respect to UTIs. So physical therapists often will notice, as Kathy mentioned earlier, that spasticity will worsen, or you may have an abrupt onset of a lot of weakness or fatigue, and that can be a red flag to the physical therapist or to the person that they may be dealing with an infection, whether it be an upper respiratory tract infection or an infection of the bladder. So often if we notice that change, it's pretty abrupt, no other symptoms, it could be a silent UTI, and we encourage people to go get checked. Additionally, pelvic floor physical therapy can really be helpful for some folks. And what they do is they do Kegel exercises, and they emphasize strengthening the pelvic floor as well as strengthening the lower abdominal muscles and the pelvic muscles that help to support the bladder. Not every physical therapist does this type of PT. So what I would advise, if you want to find a pelvic floor physical therapist and your healthcare provider supports that, because not all types of bladder conditions can benefit from pelvic floor PT. But if your healthcare provider advises it and you need to find one, I would check the American Physical Therapy Association's website, and you can find a women's health physical therapist who specializes in pelvic floor rehab. And usually PTs who specialize in hand, or occupational therapists who have more training in hand rehabilitation, can help with some of those fine motor skills that are required to use some of those catheters that Kathy had described for us. And we don't have a dietitian on the panel tonight, mainly because I don't know where we would put her on the screen. But she would definitely reiterate the importance of fluid intake and to recognize and identify what are those bladder irritants and what do we need to do to minimize that. So yes, a dietitian would also reiterate and encourage all of the same messages. Next slide. So now that we've spoken a bit about infection management, we're going to move on to this next vignette. Despite using my walker, I am still exhausted and falling nearly daily. I am terrified to use a scooter or a wheelchair because if I start to use it, I may never walk again. I hear this a lot in rehab. People are concerned about giving up their walker and losing any ability they have. So let's move on to this polling question. Let us hear what you say. Have you or your loved one with MS fallen in the last 6 months? Okay, so a little over half. That's actually really pretty better than I expected. So let's talk a little bit more about falls and how we can manage those and prevent those. Next slide. So we'll first start by defining a fall. And a fall is a kind of a sudden, unplanned loss of balance. So in this situation, you could hit the floor, you could run into another person, you could fall back into a bed or a chair. But I think what's most important about a fall or any loss of balance like this is that we investigate. We kind of put on a detective hats and figure out what are the circumstances of those falls. We would love to hear every patient walk in our doors and say they do not have a fall, but that's completely unrealistic. So when falls happen, we want to know when it happened, the time of day, any other contributing factors. Were we going off to the bathroom really quickly? Was spasticity kicking up? Did we trip on something? Were we turning? What were those circumstances? Because we know falls, especially those falls that result in fracture, can contribute to that loss of reserve. And when you start to have something complicated like a fracture, it really makes it an uphill battle to try to get you back to that previous level of function. Next slide. So why are falls common and why are they so complex? So I'm going to try in one slide to explain how balance works for all of you. So there are essentially 2 columns that we can think about, and you all can see that. The first column is the sensory input, and the second column is the motor input. So 3 systems that help with the sensory input to our brain and our nervous system about balance: our vision, our inner ear, and the muscles and nerves in our legs. So what our vision does, it gives us that visual acuity, that visual input that we get to our brain to move around objects or look out for objects. The vestibular input comes from our inner ear, and our inner ear is actually positioned behind the external ear itself. And what the inner ear does is it interprets rotational movement as we turn our head or turn our bodies. It also interprets translational movement as we move forward or backwards, or vertical movement as well. And that message is sent from the inner ear via the brain to the eye muscles to keep our vision steady. That's the motor output as we move around. The last, but certainly not the least system, is the somatosensory system, and that's our proprioceptive input. That's kind of a fancy dinner party word you can use, but really what it is that kinesthetic awareness. It's that body awareness, that ability of the sensation to go from your feet to from whatever surface you're sitting on, up to your brain, into the brain. The brain processes it and sends it back out to the muscles and nerves and tells you how to balance and keep your equilibrium. So this is great, but how does this apply to real life? Say you need to get up in the middle of the night and go to the bathroom. Quite common. It's a little bit darker, dim light, so you don't have that visual input. So in theory, you have to rely on those other two systems, more of your vestibular input and your somatosensory input to help you stay steady. Now let's add an extra layer to it. If we don't have that visual input as our optimal visual input, and we have numbness and tingling in our legs, say because of MS, then we're increasingly reliant on our vestibular input for balance. But in that type of a situation, we also are a little bit compromised, right? So we're using one sensory system primarily to help us stay steady. So not only in that situation where we try to do exercises to, heighten the other systems and the contributions for balance, but we also might consider other tools and adaptations and ways to keep people safe. So next slide. So Kathy, tell us a little bit about what you look for when you hear about people falling. What are things that are your focal points?
So one of the things obviously is, to try and prevent the fall altogether, but that sometimes is not very realistic. So if someone would fall, we would hope that their bone density would be at least decent. So that is a factor with calcium and vitamin D intake. Most of you likely take vitamin D, which helps calcium absorb. But typically what we will do, especially in individuals who have received steroids, and especially anybody over 50, bone density monitoring at least every year to 2 years is important. If that bone density is low, or if there is osteoporosis, then we do recommend, bone builders to reduce the risk of fracture with falls. And also we look at medication influence on falls. So many times with spasticity, you all may be on things like baclofen or those anti-spasticity medications, which are great. They reduce the spasticity, but the other end of it, they can cause a little bit of weakness too, because they actually relax the muscles. Other drugs like other things like clonazepam or benzodiazepines, anything that might make you sleepy, also really increase the risk of fall too. So looking at the medications, blood pressure, some of you that may be on some urinary meds for retention, or blood pressure medications, there can be something called orthostatic hypotension. When you change position, you can feel a little bit dizzy, and if people get up prior to that blood pressure equalizing, there's also a risk for fall. And other conditions like osteoarthritis, sometimes just bad joints can contribute to falls too. So there's lots of things that we kind of look at, like investigators, as Mandy said.
Right. So it becomes just really, really critical, again, that you're really detailed and as comprehensive and as thorough as you can be when you're communicating to your healthcare team about times when you feel your balance is compromised or times when you've had falls, because there are many things that can be done. And from a rehabilitation standpoint, things that we would look at is our surfaces. So you see that gal in the nice black pumps, clearly not the most ideal shoes, not what we'd recommend. So we look at shoe wear, we talk about surfaces, if they're uneven surfaces. I've often seen clients too that if they wear a tennis shoe that has too much cushion, it's almost like they're walking on an uneven surface all the time, or they're moving on that, and that can almost in a way inhibit or kind of scramble, if you will, the message from the feet to the brain about where the balance is, which can minimize the motor output for balance as well. So footwear can be pretty important. Surfaces, make sure if you need a place to sit down to minimize your risk for falls, sit down. Know your body, trust your body. You are the expert on your body. And then there are times where we need to use tools and adaptive equipment, like the scooter that you see here, and the walkers and wheelchairs and canes that we've spoken of briefly already. Next slide. But the great thing is that in addition to some of these compensatory strategies that we use, meaning those tools and environmental modifications, there are also evidence to support the value of balance exercise and balance rehabilitation. And I just highlighted two of the more recent ones that I think are pretty exciting. So between 4 to 6 weeks of vestibular training, which vestibular exercises are very specific types of exercise to train that inner ear. But those protocols, those vestibular training programs, not only reduced fatigue, but they also improved balance and improved ADL function. So not only did we get better balance, but we got carryover into daily life, which is like the holy grail. That's what we always want to do, is improve function. And these were folks who were using canes or walkers in the second study. The first study were folks that were variable levels of mobility aids. But in addition to vestibular exercises, there is evidence to support balance retraining for equilibrium, strength training, aerobic exercise. There's even some exciting research that's starting to emerge about high intensity interval training and how that can have an impact on mobility. But overall, what we know is that exercise can help balance, exercise can help improve that reserve, and hopefully reduce your risk for falls. Next slide. So next vignette. I use a walker now all the time. I used to go on walks with my spouse for exercise, but now I am too exhausted. We both are gaining weight. Next slide. So weight management is something we hear about a lot, right?
Yes.
So, and it becomes tricky because we have to acknowledge that as your it's hard, and as your mobility declines, or as movement becomes harder, it's hard to want to move, it's hard to want to exercise, it's hard to know what exercises to do to optimally help you lose weight or gain weight if that's what you need. And secondly, exercising in a body that is feeling very unfamiliar all of a sudden, which can happen when you kind of make that shift into secondary progressive MS, is difficult. So this is the time when you need to engage your physical therapist, your occupational therapist. And when you see a physical therapist, they're probably going to encourage you to do some types of exercise. And this could be flexibility exercises, strength training, aerobic, or balance. But in addition to that, we may also encourage you to increase your physical activity. And when we say physical activity, we're referring to all of the other movements that you do during the day. So any movement that you do beyond a laying down position. So that might be folding the clothes. That might be standing at the counter. That might be talking on the phone. That is, as long as you're moving around and gesturing, that's physical activity. That could be gardening or playing with your kids. But we encourage increased physical activity because research is emerging about the value of increasing physical activity, its positive effects on comorbidities, and as we've spoken of already, likely reducing some of these secondary complications. So what a physical therapist will also do is help you not only prioritize the movement for yourself, but also talk to you about what's important as far as movement with your significant other. I think, again, as the responsibilities start to shift and the support partner or the support team may start to become more responsible for some of the physical roles in the house, that ability to do things together changes. So maybe rather than going on a walk together, this couple could consider going on part of the walk together with a walker and then using a scooter the rest of the time so they can still be together and enjoy that time. Now, if you go to an occupational therapist might figure out ways to make cooking easier, simplify cooking, maybe get you a rocker bottom knife. I know Can Do MS has lots of really great webinars available online where you can figure out some of the cooking strategies that our occupational therapists recommend. And certainly then also staying cool in the kitchen. It's hot. When it gets hot, it's hard to stand. It's hard to do a lot of the things that, like Kathy said, it decreases our reserve, so it becomes really difficult to want to move. Next slide.
So weight management, I think it's important to know if you're overweight or underweight. So BMI is important. There is some downsides to BMI, but it's easy to calculate. So what I tell individuals in clinic is, really get to your ideal BMI. If you're overweight, it's just harder to move about. It's, it magnifies disability if you're over or even underweight. So you can get aerobic even in a wheelchair. And in fact, if you know about cardiac rehab, in fact, we know that you can get your heart rate up faster with your arms. In fact, people post heart attack, they say don't use your arms so much initially. But absolutely, if you do this, you can get your heart rate up faster than you can with your legs. So even individuals in a wheelchair can get aerobic. I've seen it. I see it all the time, at least where we're from. People exercise in chairs all the time. One thing we tell people is I have a lot of patients coming in and showing me these new diets, which actually are very expensive, and kind of rule of thumb is generally fad diets may work for a very short period of time, and then people usually gain weight back. What we tend to recommend is if somebody wants a program where they have to go to and check in, Weight Watchers is a good program. In general, we recommend like a Mediterranean diet where there's less sugars and processed foods. And to see a dietitian, many times in your clinics, dietitians are available, and that's always a good idea. And they can have you check in and be accountable too. Many people need to actually be monitored and weighed and be accountable. So you can also be accountable to a friend or I always have loved the buddy system. So if you have a buddy, whether it be your spouse or a friend that wants to exercise or lose weight together, that's a good deal. Next slide.
So again, I'm going to put on the dietitian hat. If she were sitting here, if our dietitian that we like to work with at Can Do were sitting here, she would emphasize these items. Nutrient dense versus calorie dense. So 200 calories worth of carrots versus 200 calories worth of Cheetos, right? Like, nutrient dense, quality matters. Quantity to a certain extent is less important, but quality matters. So think of those nutrient dense food choices. The American Heart Association, the American Diabetes Association, the American Institute for Cancer Research, Arthritis, and the Mind Diet, all of those organizations advise a diet that's colorful in fruits and vegetables. And we listed some examples there, as well as avoiding trans fats entirely. So basically what all of these diets suggest, and what the diet that we suggest now for people living with MS, is a diet that's good for your heart, is a diet that's good for your mind and for your nervous system. Unfortunately, right now, we do not have a diet that is suggested for people who have MS. The National MS Society, I know they're working on a few research studies to try to nail down any more information that they can about diet, because I know that's something that people really want to figure out a way to take better control of their diets in a powerful way. But in the meantime, until those results come out, the National MS Society does have a nice pamphlet outlining a number of the diets that are popular and that are well known, where you can go online and you can read about them and find out what evidence exists and what evidence doesn't exist. So check that out, National MS Society. And lastly, but certainly not least, is just an awareness of proportion and portion. So this myplate.gov image does a nice job of showing the proportion of fruits and vegetables. Well, it looks like about half of your plate should be fruits and vegetables, as well as the portion size that you want with respect to the whole. So keep that in mind as you're moving forward with your healthy eating choices. Unfortunately, there's no room for chocolate. Next slide, please. Okay, I have secondary progressive MS now. My treatment options are limited. What can I do? We have a polling question for all of you. Do you or your loved one with MS experience any of these comorbid health conditions? So again, comorbid health conditions are those conditions that exist in addition to your MS. So I'll give you a minute to respond to that. Okay. So high cholesterol, high blood pressure, diabetes, depression, anxiety, all very common. So we do know that these comorbid health conditions are prevalent in MS and do have a profound impact. Kathy, do you want to tell us a little bit more about that?
So, and most of you did say that you, the majority of people had depression and anxiety, and that is comorbid. We know it probably has to do with more of the chemical basis of MS, as well as there's a contribution to, you know, getting the diagnosis and likely the symptoms, multiple sclerosis. So I think the really, really important thing is, you know, if you are not getting pleasure from things that you used to enjoy, that's one of the key questions. It's important to talk to your healthcare professional because there are many things that can be done for depression and anxiety. It's also very, very important if you've contemplated ending your life, and we actually ask individuals that as they come into our office. And if you have, that's very important to talk to a health professional and to talk to someone about that. And it's a deal because depression is certainly prevalent in multiple sclerosis. So that's definitely the takeaway. As far as the others, diabetes, high blood pressure, high cholesterol, chronic lung disease, we know that smoking in MS, the prevalence is smokers are more likely to have the diagnosis of multiple sclerosis, so we know it's a risk factor. And we also know that if you have multiple sclerosis and you continue to smoke, that that is associated with more progressive disease. And I know it's very hard to do, but stopping smoking, especially when you have MS, is very, very important. There are lots of maneuvers and medications that can help smoking cessation, and it absolutely can be done. What's interesting is that the number of people who smoke is less in MS, but the people who do smoke, especially with disability, tend to smoke more because it's a go-to. So it's important to stop that. And then that can also improve the other comorbid conditions like high blood pressure. It's important here as we look at these to have a primary care physician that you can talk to, that you trust, that you can get a hold of. So that's really, really important because all of these things lower that reserve and can contribute to that progressive course in secondary progressive MS. And that's about it on that one. And so this is just more statistics, pretty much what we have just talked about. So next slide.
So this is our final vignette. My power wheelchair has been a great help with allowing me to keep working and stay involved with my kids' activities. But I'm sitting too much, and now I have developed a pressure sore and terrible swelling and redness in my legs. Also quite common when we increase power mobility use. So Kathy, I'm going to let you start us off by talking a little bit about skin integrity.
So skin integrity, so when paraplegia or difficulty ambulating occurs, or paralysis occurs, and individuals have to use wheelchairs more often, and there's less mobility, there is more chance of skin breakdown or pressure ulcers. So the important thing again is to prevent this from ever happening. If there is a pressure ulcer and it gets severe, then it is really devastating for people. It's catastrophic. Sometimes people are hospitalized. Sometimes there's infections related to it. And then really not many people will get back to that baseline after these things. So again, the important thing is prevention. So inspect. So what we tell people is daily inspection of skin. And sometimes that's tough, especially if you live alone. But if somehow you can get your skin inspected, some people will use mirrors, especially if you're having any pain. So it's important to get a look at it. And sometimes people come to our clinic, especially in one of our clinics, where we actually look at the skin on their bottom and make sure everything is okay. Report any new pressure sores, any new redness or pain in the hips or where you're sitting. Investigate its presence. Sometimes, with sensory loss, as you talked about, Mandy, there can be actually people can be sitting on things and not even know it, like whether it be a tube or something. But investigate if there's any redness. Investigate what it's coming from. There's something called pressure mapping that occupational or physical therapists do. Sometimes durable medical vendors do that, where they can actually see what type of cushion you need or where the pressure points are. It's really important to reposition every 30 minutes. If you have good use of your arms, this is perfect. You just move yourself out of the chair, reposition. If you don't, if you're not able to do that, then if you have a tilt power chair, you tilt the chair every 30 minutes. And that's very important. Nutrition and hydration, again, are important here because it keeps the skin supple. Really dry, dehydrated skin is more likely to break down. Offload the area if there is redness or you do have a sore. We recommend that people get out of their chairs for an hour or two in the afternoon and offload, and at night completely be off that area of pressure. Evaluate your toilet time. We have seen people get pressure sores from actually sitting on toilets or the use of different durable medical equipment. So evaluate those sort of things. Whenever there's a new piece of equipment, including a new wheelchair, it is so important to look at the skin, make sure that there's no pressure, especially in things like slings and braces. Many times that we have seen these as sources of the problem. So if you see that, you discontinue the use of that equipment and notify, your providers or your MS physical therapists or occupational therapists.
Can I add with your comment about
Yes.
the braces? So sometimes folks, when they get a new AFO or one of the ankle braces that can help with drop foot, especially if it's one of the plastic ones,
Yes.
or the custom molded ones, we really have to be careful and check any of the pressure areas along the foot and along the ankle. And sometimes that can be molded and changed along the way. But anytime you start a new brace, generally we recommend for people to gradually work in that so that we can have that opportunity to inspect skin. Next slide.
So we get this a lot too, as there, with MS, there can be paralysis as time goes on, especially with spinal cord lesions. So really it is just like a spinal cord injury. So what can happen is as the lower extremities become weak, the muscles aren't efficient in pushing the fluid back up. So good news about this is it's not arterial. You're getting enough circulation. The problem is you're just not getting the circulation back. So fluid tends to pool. So it can also be caused by braces, tight braces or shoes. Even sometimes the things we use to prevent this sort of thing, like compression stockings, can actually roll up and cause the actual thing that you're trying to prevent. So a good important thing to do is elevate the legs as much as possible, compression stockings that fit and that you're able to, apply appropriately. Movement and exercise is also important. So if we get some of that strength in the muscle back, that's efficient in pumping some of that fluid back up. And then again, inspect when there's swelling. There can be more, potential for injury too. What's interesting about this type of swelling with this, what we call decreased venous return, many times the foot is red or discolored. And a good thing to do is elevate it above the level of the heart, and usually that color goes right out of there. So the redness just resolves, and we know that that's a venous return problem. So next slide.
I'm just going to add one or two things too. Sometimes when exercise becomes difficult and you do live independently, sometimes tools like neuromuscular electrical stimulation devices that you can put on I'm thinking mainly the foot and ankle or the lower leg that can help to move the ankle up and down without you moving it itself are things that you can try to give you that exercise and give you that movement to help with the circulation and the fluid when other assistance isn't available. So what else can you do from a rehab standpoint? If you're someone who needs a new cushion or wheelchair modifications, we often recommend to touch base with those physical therapists, occupational therapists, or folks called assistive technology professionals, ATPs. Those are the folks that really know the equipment and know the mobility devices quite well. Generally speaking, and Kathy, you can tell me what you recommend. Generally speaking, cushions last about 3 years. It's pretty fair. Wheelchair modifications, you need those to help with skin integrity and to help with proper seating and placement. If you don't have foot plates, then your legs are dangling, and that can put pressure on your seat and your buttocks differently. If your foot plates are too high or they're too low, that can change how your bottom bones and the pressure in your bottom bones, and that can really have an impact on skin integrity. Kathy talked about the tilt in space. So the tilt in space keeps your chair in a chair-like position, and it just tilts you back, whereas a recline actually reclines you and straightens you out like a lazy boy recliner. Both have value, and often spasticity in the lower legs and the lower extremities are what dictates what kind of repositioning is most effective for you, but talk to your therapist about that. So in addition to those wheelchair modifications, PTs could also help you identify those exercises for your abilities. So everybody can exercise regardless. Never go to a therapist who says there's nothing they can do for you. There's always something that can be done. So exercises for your abilities. And an example I have here is a standing frame. Simply standing, giving you that weight bearing, giving your muscles the opportunity to contract and stretch can be really helpful, and also helpful for your skin integrity as well. Position changes, Kathy spoke about that. Doing a tricep to give you a little bit of pressure reduction. Generally every 15 to 30 minutes, some type of pressure reduction or change of position. The tricep press up can be a nice one, even leaning to one side for generally 30 seconds to 90 seconds is what we recommend, leaning to the other side. Even we have some folks who just simply lean forward a little bit to off-weight their bottom or to change that position. But talk to your rehab team, figure out what strategies work best for you and what are most optimal for you to save your skin. Next slide. So I think what's important, and what we've touched on a little bit, but I want to add, is the impact that this shift into secondary progressive MS can have on support partners physically. So again, they're taking on potentially more roles. Maybe they're helping with transfers. Maybe they're helping with more of the cooking. Maybe they're helping with more of the driving. Whatever the support person is doing, they just may be doing more of it. There may be, like I said, there's a shift of role. It can be really stressful for some of them, and they may feel a lot of worry. So I think it's important for us as healthcare providers to ask the support person, they're kind of the invisible patient, if you will, and talk to them about how they're feeling, how they are adapting, how are they adjusting to this shift, and what can we help them with as well. And if your healthcare provider doesn't ask you, support partners out there, ask your healthcare provider. Similarly, I think it's important for the support partners, again, as this shift and this change is happening, to remember to prioritize their own wellness, and to remember that it's important to still exercise as much as you're able and take care of yourself, take care of your comorbid health conditions as well. Next slide. All right, let's just general strategy summary before we move on to question and answers. MS is complex, clearly. Use your team. If you don't have a team at a comprehensive MS center, start piecing together your team from those folks in the community that you connect with. If possible, when you go to healthcare visits, bring an advocate, bring someone who can help you remember, who can help ask those questions. Recognize that different symptoms can be optimally managed by different team members. But I would also add, even if you don't see the team or know the team member who can help you, tell somebody. Tell somebody. I have patients tell me all the time that they're struggling with other issues, but recognize that telling somebody is going to be the step forward to getting it addressed. Wellness strategies can help to influence those comorbid health conditions and impact overall MS symptoms. So overall, hopefully the message that you've gotten is that you can control what you can make a huge impact. And when you learn and have key strategies that you've really had great success with, pass them on to others.
Yes.
You all are the experts, you really are. We learn from you, and we want you all to learn from each other. So next slide.
And we're just going to end with the tank, and just a reminder to keep your tank full and optimize wellness and health. Keep your reserve high. And we'll switch it over to Laura now.
Terrific. Thank you guys so much. I loved having you present, together and give us that information. And it was a great balance between the physical therapy and the nurse practitioner. So that was terrific information, and I appreciate it. We do have some time for some questions and answers. So the first question I'm going to ask is to Kathy. And we always talk about how one's individual journey with MS is always unique. So the person we've been asked is, why do some MS patients progress despite all treatments and others stay the same? I know it's a tough one.
That is a tough one. I think it still has to, in my opinion, it still has to do with those tank pictures. And there can be some, I think the real important thing, now we know this, and many of you may have been, again, diagnosed before we have this armamentarium of medications. But I think the really important thing is really to prevent this in the, as time goes on, is to really get at it early and to get at it accurately. To treat, now there's a concept in MS called NEDA, so no evidence of disease activity, and that means no MRI lesions, no relapse, no progression. So those sorts of things are relatively new. 10 years ago, we didn't have those. But I do believe that progression that we see is, again, it's tough to tell, but I think it does have a lot to do with reserve. I mean, as we age, especially, that does decrease, so we're more likely to manifest these symptoms. I really hope that may have answered your question. Some people have very, very aggressive inflammatory disease early, and many times that's where all that damage begins. So, I wish there was something we had to reverse that,
Right.
But we don't. And hopefully we will, but that's the best explanation. I hope I answered your question.
Great, thank you, Kathy. So we did have a question that related to the UTI issues that you talked about, and the question is: are the at-home tests for UTI accurate to test for UTI? That's
a very good question. So I think under certain circumstances they may be. If you do not have a catheter, I think they're pretty accurate. And if the specimen is clean, if you're using a dipstick. So indeed, if you do not have a catheter. However, if you do have a catheter or you're doing intermittent catheterizations, there is bacteria present, and that's going to give you a false positive. So we know that with catheters, something called colonization happens in a week. So you will have bacteria in your urine. So The answer is, I think they're pretty good with people that do not have catheters to test for urinary tract infection.
It's a good question.
Great.
Good question.
Mandy, I know we talked about, when we talked about balance and falls, we had a participant that came up with a question saying, have you heard of a balance vest to aid in balance to help reduce falls?
Yeah, so there is a balance wear balance vest, and it's it's a vest that you wear, like a typical vest, and there are weights strategically placed in areas to help to manage ataxia, primarily is the purpose of it. You do technically need a therapist who's trained in that balance wear technology to properly place those weights. Yes, that does exist, and it's generally indicated for folks who have ataxia.
Okay. How and where do you have a bone density test done?
So those can be done in pretty much radiology departments. They're very quick. They're usually less than 10 minutes. So some doctors' offices actually have those machines to do bone densities, but very easy to get done, either at a doctor's office, a radiology office, a hospital. Yeah.
How often do you recommend?
Well, generally every 1 to 2 years, depending on individuals that are on bone builders that have actually been started on those, and then maybe on an annual basis for a while to make sure that that drug is effective in increasing bone density.
Okay, great. Kathy, can you tell us what your what the recommendation for the maximum and minimum limits of vitamin D are?
Yeah, so what we usually generally do, we'll check a serum level. So labs vary though. So generally any serum level between 50 and 80 nanograms, some people will say between 50 and 100 nanograms are your target. But again, the labs vary. So it will depend on the individual how much actual oral vitamin D is going to take to get it there. Yeah, so it all varies. We check vitamin Ds on an annual basis to make sure individuals are, hopefully at that goal, and adjust vitamin D intake based upon our results. So 50 to 80 generally. Some people will go 50 to 100. Anything above, definitely above 150 nanograms per ml is considered toxic. So there can be a downside to vitamin D replacement also.
Okay, great, thank you. Mandy, how do we learn about vestibular exercises and who provides vestibular training?
So a physical therapist generally can teach you vestibular exercises and vestibular activities. You can go to the Vestibular Disorders Association of America, or again, I would honestly refer you back to the APTA, the American Physical Therapy Association, and do a search for a neurological physical therapist, and they would have knowledge of vestibular exercises and activities. Otherwise, if you're just looking in your hometown or you're calling around to therapists, just ask them if they do vestibular retraining.
Great. So we talked a little bit about assistive devices today. Can you recommend a good resource to look into some assistive devices? A website or a magazine, perhaps?
Well, there used to be a big catalog about, yay big, called the Salmon's Preston catalog. I don't know if you remember that giant catalog.
I do.
And it was like the Bible for physical therapists for adaptive equipment and things like that. But I mean, honestly, I wouldn't start just by flipping through a catalog anymore. I would recommend talking to a therapist, because, and the reason being is resources from insurance are so limited nowadays. Insurance may only cover a mobility aid every 2-3 years. It depends on the insurance, and I may be overly optimistic in that statement. So I would hate for you to go out and buy a mobility aid, and then it's not the mobility aid that's most suitable for optimizing your movement. So talk to a therapist first, let them direct you to a few options, then go online and investigate them a little bit, talk to your therapist again, maybe try a few out, and then go from there. So I wouldn't direct you just one place. I would actually direct you to a therapist first.
Great. Kathy, I know fatigue is a huge issue, but can you give a couple of quick suggestions as to what to do when fatigue hits and arises?
Well, the first thing that I usually do is make sure it's nothing else, because fatigue is common in other disorders too, other diseases. So making sure that you're not anemic, your thyroid isn't out of whack, making sure what we have found more recently is a lot of sleep disorders with multiple sclerosis. So many times that's the first thing that I'll ask, is that we do an overnight sleep study at home. So that does exist, at least to check out any severe sleep apnea, which can influence the entire energy level throughout the day. But as far as, energy conservation is important. Fatigue is really complicated. So you want to look at a medication list and see if there's something in that list that maybe isn't contributing quite a bit to the fatigue. If it gets down to it, there's nothing else, and we know it's MS fatigue. We do have medications for MS fatigue that are very helpful. I believe the MS Society has recommended, if you can, maybe take a short nap, especially after lunch, up to a half an hour. You don't want to sleep too long, but things like that. Fatigue can be tough. The other thing that can cause fatigue is and so just the mere fact of getting maybe an ice, some coolness around your neck can reduce some fatigue if it's heat related. So lots of things to work on fatigue.
That investigation.
Yeah, investigation.
Mm-hmm.
Yeah.
Great. Lots of great information this evening. You know what? We are actually close to the end of our webinar, so I do have some things to go over before we finish up. But I do want to thank you both for some great information tonight and really putting it in nice, easy to understand material. So thank you for that. And as we conclude, I would like to talk about some of the resources available from Can Do MS. On the Can Do MS website, you'll find our archived webinars, our e-news, our library articles, and Can Do On Demand. You can also submit a question to ask the Can Do team, which will be answered by our team of MS experts. People ask us all the time, how do we get involved in Can Do MS? And there's a bunch of ways. You can start a fundraiser through our Kick MS campaign. You can buy a loci bracelet. You can do monthly giving. And it's a really neat thing that's happening right now is on Facebook, there's this trend to give up gifts and ask for donations instead of getting gifts. So if you have an interest in giving back to Can Do MS, these are a couple of ways that you can get involved, and I would encourage you to participate. We do have one more webinar in this series, and it's called Managing Transitions in Your Partnerships. And if you recall, our second webinar in the series, we met Anne. In this fourth webinar in the series, we're going to meet Karen, her partner. Roz will also be moderating that webinar, so we're really looking forward to it. So again, I want to thank our partner, Novartis, for working with us on this webinar. And finally, we are going to have a survey pop up on the screen after the webinar is over. And again, thank you, Kathy and Mandy. But most importantly, thank you all for participating tonight. It is such great to have a large audience, and we really appreciate you participating in these webinars. So thank you, and have a great evening.